Hey, today we're going to tell you about embolic stroke. It's the second most common type of stroke and one of the biggest killer diseases in Australia. By the time we finish our in-service today, you'll understand how embolic strokes form, identify the signs and symptoms, find out how we diagnose them, know the pharmacology, know what to consider when looking after a patient who's had a stroke, understand what factors impact a patient's prognosis, and know how to educate your patients about subsequent stroke prevention. But first, let's talk about how strokes form. To do so, we're going to take a look at what is happening inside our patient Dylan. This is embolus. Embolus was formed inside Dylan's endocardial layer of his heart. Now Dylan has atrial fibrillation or AF. 20% of people who have an ischemic stroke will have AF. It's the biggest risk factor because AF means the heart isn't pumping as effectively as it should, and blood pools and stagnates. This is how embolus was formed. Now embolus has been here, getting nice and plump, and is pumped and ready to head off into the bloodstream. Off you go, embolus! So as you can see, embolus has exited the heart and is off into the circulation, headed towards the cerebral arteries, and he's now reached the brain. Oh no, embolus is too plump and he's got stuck in the skinny cerebral arteries. Behind embolus there's blood building up, but it can't get past. This causes ischemia to the areas where there is no blood flow. This is called a brain infarct, and within 5 minutes the parts of Dylan's brain that receive no oxygenated blood are going to die.
An embolism is some type of traveling mass in your bloodstream, and it's most often a little blood clot. So in an embolic stroke, this little blood clot will travel up to one of your cerebral arteries and get stuck and cut off your blood circulation to that area. So let's say it gets stuck somewhere about here. It's traveled up through the internal carotid artery and is lodged here in the middle cerebral artery. And now parts of the brain served by that MCA, that middle cerebral artery, are all going to start to die off.
Now you may be wondering what the outward signs and symptoms that you typically see in a patient experiencing embolic stroke are. We were going to sing this for you, but we worried it might give you a stroke, so we got the professionals in.
Jenny and her grandma May on an ordinary day, when they're in the kitchen, Grandma started to sway. Grandma sounded strange when she spoke, and Jenny had to ask, what if my grandma's having a stroke? I think I better act fast. I think I better act fast. Does her face look a little bit uneven? Does one arm drift down? Is her speech coming out kind of strangely? Then it's time to call 911.
If someone is having a stroke, you need to act fast. FAST. The acronym stands for
F is for face. First, identify whether the person is experiencing any sudden drooping, weakness, or numbness in their face, or if they are experiencing vision issues. A is for arm. Test for numbness or weakness in the arms and legs in one or both sides of the body.
Ask them to hold their hands out. Anyone should be able to hold their hands straight out and maintain that muscle tone. The person that's having a stroke, that one weak side will slowly drift down.
The body. S is for speech difficulty and comprehension. Identify any signs of difficulty speaking or slurred speech. You should also look for difficulty in the patient's comprehension of speech.
Well, a very, very heavy debatation tonight. We had a very Darrison, but let's go to Terry's and look for the head of the pen.
T is for time. This is a reminder that during an embolic stroke, time is crucial in reversing any damage to the brain. The sooner these signs are recognized and treated, the better. If you see these signs, call an ambulance immediately, because the paramedics can begin treating the patient on the way to the hospital. The first 4 hours after symptoms present are the most critical because the most effective treatments are only available during this time.
Hopefully your patient has come into a stroke ward because patients treated within a stroke ward have lower mortality rates and lower levels of disability. But now what? The patient will be examined by a doctor and nurse who will do a number of diagnostic tests to identify that the patient is having a stroke, the stroke type, and the most appropriate treatment option. The most important test is a non-contrast CT scan, which gives us an image of the person's brain and neurovascular health. It is widely available and fast, and this is the gold standard for identifying the type of stroke and its location in the brain. It provides us with images where we can see where the embolus is formed within the brain. You can see here where the embolus is lodged. Non-contrast CT scans produce a contrast between the light, high attenuating clot and dark, low attenuating cerebrospinal fluid. The reason we need to identify whether a person is having a hemorrhagic stroke or an ischemic stroke is because they are treated very differently. And if you give the wrong kind of treatment, your patient is going to die. So it's pretty important to know which type of stroke your patient has. After all, you don't want to be this nurse. So back to our friend Dylan and his pesky buddy Embolus. What should we do about him? Now, Dylan was really lucky and he got to the hospital really quickly. He only had a stroke an hour ago. Since he's been here, he's had a CT scan and received the diagnosis of embolic stroke. Let's go back to the playground, that is, back into Dylan's cerebral arteries. If embolus stays where he is, blocking blood flow and causing ischemia, then Dylan is going to end up with some pretty severe brain damage. Let's show you the main treatment doctors will use to remove embolus and revasculate that artery and hopefully save some of the ischemic brain tissue. The main treatment is called recombinant tissue plasminogen activator, or RTPA. RTPA is a thrombolytic drug that is administered intravenously. It essentially dissolves the clot. RTPA binds to the fibrin protein threads of an embolus. It converts the enmeshed plasminogen to plasmin, initiating local fibrinolysis, where enzymes break down the clot. This produces limited conversion of plasminogen in the absence of fibrin, thus causing a limited systemic effect. The effect of alteplase is to dissolve clots so that blood flow can be restored and viable tissue can be reperfused. RTPA is going to maximize Dylan's survival rate and lower his ongoing disability from the stroke, but only if he gets it within 4 hours. RTPA basically shoots down the artery or slides towards the embolus and breaks it up into lots of little pieces. Recombinant tissue plasminogen activators, like alteplase, can cause hemorrhage, so consider drug interactions and contraindications. Anticoagulants, like heparin, can cause drug interactions with alteplase. Other contraindications that increase the risk of hemorrhage include uncontrolled hypertension or head trauma or stroke in the previous 3 months, the type of stroke, any internal bleeding, or recent surgery. There are other less effective treatment options for embolic or thrombotic stroke outside the optimal 4-hour treatment window. These options are not appropriate for hemorrhagic stroke because they are likely to cause further hemorrhage. These include aspirin orally or via a nasogastric tube or suppository for those with dysphagia. This should be given as soon as possible after the onset of stroke symptoms within a 48-hour period. Treatment for stroke is often done in conjunction with blood pressure lowering therapy, oxygen therapy for hypoxic patients, and glycemic control for diabetic patients. In caring for a stroke patient, we also need to consider appropriate diet, nutrition, and ability to swallow, because we don't want patients to aspirate or become malnourished. We also want to observe for neurological changes after a stroke, especially assessing their level of consciousness. We might also consider referral to other disciplines like the dietitian, GP or physio, or palliative care if it is appropriate. We should also think about the patient's psychosocial needs. What is their background, culture, and housing like? What kind of support will they need in the future? Also, their social support. What level of support do they have around them? Finally, planning for discharge. Are there changes that need to be made to their medications? For instance, can the patient take pills? What equipment and support services need to be in place to ensure a safe discharge? There are many factors that influence a patient's outcome after stroke. These include age, ethnicity, location, and how quickly they received medical intervention, and also where they live. For instance, people living rurally are less likely to have access to a stroke unit or receive treatment within the 4-hour window for alteplase. These patients are more likely to have a greater chance of death or more disability long term. The general health and other comorbidities are also likely to affect their long-term prognosis.
We'll get it. Oh, hi.
Who is it?
Shine.